complete the sign-in process through the Cloud CME mobile app or text 31800 to 844-420-1171 or use the single sign-on option. These numbers are on the screen, and Catherine will send them out again at the end of the session. We also ask that you please mute your microphone and turn your video off. Now, please go ahead and pin our guest speaker, Dr. Larissa Neklyudov. And to do this, right-click on the presenter's name icon and then select the pin option. So this way you could have her on your screen and her slide. And with that, I am pleased to introduce our key speaker, Dr. Larissa Neklyudov. She is a professor in the Department of Medicine at Harvard Medical School and is a practicing internist at the Brigham and Women Hospital in Boston, Massachusetts. She's also clinical director, internal medicine for cancer survivorship at the Dana-Farber Cancer Institute, where she offers clinical care for long-term survivors of childhood and adult cancers. Dr. Neklyudov is particularly interested in improving the care of cancer survivors and the interplay between primary care and oncology care. Dr. Neklyudov has been at the forefront of the field of cancer survivorship, nationally and internationally, by leading and participating in the development of survivorship care policies and clinical guidelines, educational programs, and research. Her scholarly publications, including journal articles, book chapters, and 2 books, as well as her broad-ranging educational programs, have promoted awareness among healthcare providers about the ongoing needs of cancer patients across the care continuum. Throughout her career, Dr. Neklyudov has been dedicated to teaching and mentoring students, residents, and fellows. And with that, we welcome Dr. Neklyudov, and we will turn the computer and all systems to your talk. So virtually, please help me welcome her.
Can you all hear me while I queue up my slides?
Yes.
All right, terrific. All right, well, thank you so much for inviting me to present to you today, and thank you for that introduction. Clearly, I would have much rather done this talk in person, but since we're not allowed to do that at the moment, I'm glad that we were able to do this virtually. So I will do the following during this talk. I will give you an overview of cancer survivorship and areas of focus in cancer survivorship care, describe the role of primary care providers may have in the care of cancer survivors, review strategies for education and training, both for primary care and oncology care providers, demonstrate bidirectional integration of primary care and cancer survivorship care, and then I will end with a little bit of my experience. So primary care providers play an important role in caring for patients across the cancer care continuum, from prevention and risk reduction to screening to diagnosis, treatment, survivorship, and end-of-life care. For the purpose of this presentation, I'm going to focus on survivorship. So first, to begin with, who is a cancer survivor? And this is a definition that has really now been agreed upon by many organizations, including the American Cancer Society, the NCI Office of Cancer Survivorship, and also the National Coalition of Cancer Survivors. And it's really any person with a history of cancer from the time of diagnosis through the remainder of their life. So what does that mean? That could be somebody living cancer-free after treatment for the remainder of their life. somebody living cancer-free after treatment for many years, but then experiencing one or more serious late complication of treatment, living cancer-free after treatment for many years, but then dying after a late recurrence, living cancer-free after the first cancer is treated, but then developing a second cancer, or a third or a fourth, living with intermittent periods of active disease requiring treatment, and living with cancer continuously, with or without treatment, without a disease-free period. And it's important that we really focus on the entire spectrum of cancer survivorship. So the statistics have shown that over the past several decades, the number of cancer survivors, and these are individuals living with and beyond cancer, has increased significantly in the United States. You can see in 1975, when these statistics were first started being tracked, there were only 3.6 million survivors. In 2019, there were 16.9 million survivors, and by 2040, we're expecting 26.1 million survivors in the United States. The other piece that is really important to notice in this figure is that the age of cancer survivors and the percentage of older cancer survivors is increasing. So that means that not only are we going to have more and more cancer survivors in the future, but they will be older, and that means that they will have other comorbid chronic medical conditions that will need management in addition to their cancer. In 2005 and 6, there was a landmark study that was conducted by the Institute of Medicine, now National Academy of Medicine, and I'm sure and I hope that this is familiar to many of you here today. And this was a study from cancer patient to cancer survivor lost in transition. The goal for this panel was to raise awareness of the medical, functional, and psychosocial consequences of cancer and its treatment, define quality healthcare for cancer survivors and identify strategies to achieve it, and improve the quality of life of cancer survivors through policies to ensure their access to psychosocial services, fair employment practices, insurance. Slides are not moving. Okay, let's see. And so you're not supposed to read this slide, but these are 10 recommendations that the IOM made in efforts to improve the transition of cancer patients to survivorship. And about 10 years later, I, as well as some of my colleagues, went back and looked at the 10 recommendations that were made to assess what progress has been made and where the gaps remain. And what we found was that there were definitely a lot of progress that was made, but there were still very significant gaps remaining. So what is quality survivorship care? So I spent about a year and a half working as a visiting scholar at the National Cancer Institute. And through a variety of different ways, my colleagues and I developed what's called a quality cancer survivorship care model. For the purpose of this presentation, I decided to spare you the very complex model and really just focus on things that were very clinically relevant. And so these are the focus areas in cancer survivorship care, and let me walk you through these. So the first one is prevention and risk reduction pertaining to recurrences and new cancers, as well as surveillance methods. And so this is really the major focus of cancer survivorship care, particularly among oncologists. And so for primary care providers, my general suggestion is that PCPs just need to have a general awareness of modalities of cancer recurrence and modalities of surveillance and patterns of recurrences. So what do I mean by that? So for example, for breast cancer, a primary care provider needs to be aware what are the general ways that breast cancer can recur, and what are the different ways that we can surveil for recurrences. Is there a role for examination, for laboratory testing, for imaging? When should surveillance happen, and how long does that follow-up need to happen? And then who is doing the monitoring? Is it the primary care provider? Is it the oncologist? And the goal here is just get it done. And that you will see as my theme across all of cancer survivorship, which is we need to focus less on who is doing the work, but make sure that the work is being done. And then, of course, in that domain is prevention and risk reduction, which means being aware of genetics and family history. So, for example, what I find is that when a patient is diagnosed with cancer and they're seen by an oncologist, typically the oncologist will do a pretty thorough family history. But that kind of goes away, after years of follow-up in oncology. And I rarely see an oncologist update the family history. So it's important that for both oncologists and primary care providers, that there is a continuous monitoring of family history as things may change. And so it's important to assess and then refer as needed. And then, of course, hormonal adjuvant therapy and making sure that the patients are actually adhering to the regimen that has been prescribed. So the other piece of cancer survivorship care, and one that is paid slightly less attention to than the recurrence one, is paying attention to physical effects of treatment. And in this regard, really, it's the job of both the oncologist and the primary care provider to be aware of possible physical effects, to screen for potential effects, manage them accordingly, making sure that they are referred to appropriate healthcare providers. And I won't go through this in much detail because I know that the program that you have will touch on many of these. But I do want to just raise the fact that in paying attention to late and long-term effects, it's important to consider the surgery, the chemotherapy, the hormonal therapy when it comes to medications. If somebody can mute themselves in the back, that would be great. We also need to pay attention to late effects pertaining to radiation therapy, and these can be non-malignancy related and then malignancy related. And so again, I noticed on your program that you do have a talk focusing in on that. Of course, immunotherapy is a brand new tool in the oncology world. And so the goal here is for both primary care providers and oncology providers to really be aware of the potential effects. And usually the guidance that I provide to my primary care colleagues is when somebody is on immunotherapy, just be prepared for anything. And if a patient comes to you with any symptom, any itis, then be sure to touch base with the oncology colleague to be sure that these are adequately diagnosed and managed. So then we're going to move on to the psychosocial effects. And with that too, it's really the job for both the primary care physician and the oncology providers as well. And this we don't do very well, neither in primary care or oncology. And the important piece here is, again, awareness, screening, management, and referral. So what are the potential psychosocial effects? They include psychological. And so attention to the psychological well-being of cancer survivors is growing, but is still suboptimal. Fear of cancer recurrence is prevalent, and we need to address that routinely with our patients. Anxiety, depression, and fatigue are very common. The other one is the financial, employment, and school issues. And so these are important areas where all of us really need to address and discuss and refer our patients to appropriate venues. And then, one that is often disregarded is attention to sexual health. Of course, this could be a physical effect as well. If somebody had pelvic surgery or pelvic radiation, or if somebody has dryness as a result of hormonal adjuvant therapy. But the important piece is to ask the questions, assess, and refer appropriately. So those top three are really areas that could be seen as really in the domain of the oncology care. But the other pieces that really need attention are the non-oncological areas, right? I mean, we need to focus on the whole person. So if, I always say that if a patient is cured from breast cancer, but dies because of heart disease due to uncontrolled diabetes during cancer care, then we really haven't done our job. So importance about managing chronic medical conditions. And here I would say that this is mainly the job of the primary care provider, with appropriate management and referral, but the oncology providers have to recognize. I have seen sometimes in the survivorship clinic, a patient is referred for follow-up, and I see that for years, a patient has had elevated glucose levels done on their routine CMP panels. And then I do a hemoglobin A1C, and it's, their diabetes is through the roof. And so for years, their CMP was checked, but never addressed. And then sort of along those same, So then with chronic disease, there's actually been a growing emphasis on the world of cardio-oncology, where there's greater recognition that cardiovascular disease plays an important role in cancer survivorship outcomes. And this is the latest that was provided by the NCCN survivorship guidelines, sort of raising awareness among physicians, healthcare providers, and patients about cardiovascular wellness. And that includes awareness of risk factors, blood pressure monitoring, cholesterol monitoring, diet and weight management, exercise, and then echocardiogram and EKG based on risk factors. And so, here again, you can find this in the NCCN guidelines, but again, it just underscores the need to pay attention to cardiovascular risk factors. And that might be because they had underlying cardiovascular disease risks. They might have come into treatment with diabetes or hypertension or hyperlipidemia, but it's also possible that they developed those risk factors as a result of treatment. So from radiation therapy, chemotherapy, et cetera. And then the last piece here is health promotion. And that is just general good lifestyle habits, including vaccinations for cancer survivors. And here too, this is really a job for the primary care provider to render appropriate screening and counseling. But this is an area too where an oncology provider can recognize that the patient hasn't seen their primary care provider in a couple of years since they've been undergoing treatment. Is there anything that is needed in terms of health promotion? So for example, do they need a pap smear because they've been out of the PCP world, for the last 5 years due to treatment of Hodgkin lymphoma? And so this is just a general overview, again, published by NCCN guidelines for healthy lifestyle recommendations. And these are no different than, for any other patient that we make recommendations for. And then vaccinations, again, I won't walk you through this, but generally it is important that oncology providers and primary care providers pay attention to vaccination. So generally the recommendation is vaccinate prior to treatment if at all possible. So you know that the patient is going to start chemotherapy, they're going to be immunocompromised. Don't wait until they're in the middle of their chemotherapy before you realize that they need vaccination. Vaccinate them before so that you can potentially derive the greatest benefit. And then, of course, different guidelines for vaccinating those who are not immunocompromised, those who may be immunocompromised, those who are asplenic, and then, of course, survivors of bone marrow transplant with chronic GVHD. So the 5 domains I went over are really unique to the cancer survivor experience. But what you can see here are other sort of contextual domains of cancer survivorship care. And that really pertains to the healthcare delivery. And that includes clinical structure. So that means who is providing survivorship care? Where is survivorship care being provided? Who are the healthcare professionals providing that care? Communication and decision-making, care coordination, and patient caregiver experience. So there's been a lot that has been written about the interplay between oncology and primary care providers when it comes to cancer care. And this was a systematic review looking at the literature that has been published. And what they basically found is that there is a poor and delayed communication between PCPs and cancer specialists. The cancer specialists tend to endorse a specialist-based model of care. But PCPs believe that they play an important role in the cancer care continuum and want to participate in the cancer care continuum. On the other hand, both cancer specialists and primary care providers express their uncertainty regarding knowledge and training in order to provide the care. And there are discrepancies between PCPs and oncologists regarding the roles and expectations. So again, the frequency of communications, the PCP often feel they're not getting enough communication after diagnosis and treatment. They often feel that once the patient goes into the oncology space, they never hear from them. They just disappear. And they want to be more closely informed by any means, including telephone or email. The oncologists also agreed about infrequent communication and cite logistical barriers and often too many providers involved in their care. So what might happen is a patient, let's say with a breast lump, gets referred to, and let's say has an abnormal mammogram, is then referred to a surgeon. And then the surgeon does the biopsy and finds that it's malignant, and then refers the patient to a medical oncologist. The medical oncologist will then refer the patient to the radiation oncologist. And then basically the communication loop is really among the oncology providers, and the PCP kind of falls out of the picture. And so again, here the PCPs, say that there is really deficiency in terms of how much information they're getting. And like I said, they feel like all of a sudden they are out of the loop and they have no idea what's going on. What are the possible solutions? So electronic medical records, right? They're not a panacea, but they do help. Because if you do share electronic medical records, at least the PCP can look in the EHR to see what's been going on with the patient. Of course, that doesn't necessarily mean that they were actually CC'd on their notes, but at least when the patient comes in to see the primary care physician, he or she can then look back to see what's been going on otherwise. Use of standardized communication strategies. So again, it could be through the use of EHR, it could be through email, it could be through other ways. Certainly practicing in one healthcare system is of benefit, and I often try to convince my patients whom I see both on the primary care side and on the oncology side, to try to keep their healthcare providers all in one system. Direct communication, and of course, existing relationships. And that I sometimes find, back in the day when I used to actually travel to give talks, that oftentimes in smaller communities where the oncology providers know the PCPs, those issues don't come up as often as they do in larger healthcare systems and larger cities where there may be 30 different breast oncologists practicing in one institution, and lots of primary care physicians. What's also been proposed in attempts to improve communication and care coordination is a survivorship care plan. So I imagine that all of you or most of you here today have heard of a survivorship care plan, and you might think it's a good thing, you might think it's a terrible thing, but it is something that was mandated by the COC in order to get accreditation. And so the key elements in a survivorship care plan is a type of cancer that the patient had, the treatment summary, potential late and long-term effects, follow-up plan, support services, and resources. And so as I mentioned, the COC mandated that a survivorship care plan be provided to patients who are transitioning from treatment. And this I think was a good thing in that it made cancer centers awaken to the issues pertaining to cancer survivors. Many started cancer survivorship programs, or at least nurse practitioner or physician assistants who were focusing on the development of a survivorship care plan. But this is a challenging feat. It takes a long time and a lot of effort to develop a survivorship care plan. And the data has shown that it's really not all that effective. And so as a result, the new COC survivorship standard has really moved the emphasis from a piece of paper, the survivorship care plan, to more of a program-based approach. And these are some of the ways in which the COC standard can be met by a survivorship program. So going back to the survivorship care plan, I think one of the issues with a survivorship care plan, and I think a lot of the research that has been conducted in this field, is that it's really more than just a piece of paper. Giving somebody a survivorship care plan does not necessarily alter their care. And about a decade ago, I wrote a paper, not this one, but I wrote another paper basically comparing a survivorship care plan to a hospital discharge summary. And if you think about it, a hospital discharge summary by itself does not necessarily change care, but it's the process, right? So when a patient is discharged from the hospital, the primary care physician gets a copy of the hospital discharge summary, but then there's a visit that happens. And at that visit, the primary care physician has an opportunity to review the hospital discharge summary and make sure that all the boxes are checked and make sure that everything that was advised at discharge was being done and followed through. And so really the goal here for a survivorship care plan, even though the COC has moved away from it, I think that it's still not something that we should just forget and never revisit again. I do believe that there are patients who benefit from a survivorship care plan. And then I think we need to be more thoughtful in what we do with a survivorship care plan. And what I have here in the right upper corner, Where's Waldo, is basically one of the key issues that PCP colleagues have expressed, which is a survivorship care plan is either faxed to the PCP's office and then it gets scanned, never to be found again, or it might actually appear in the EHR. And I've done experiments in my own system where I use Epic, and the survivorship care plan is there, but you really have to go through a whole bunch of clicks in order to find it. So again, I'm not saying that we need to forget about a survivorship care plan in the future, but we need to be more thoughtful in what we include in the survivorship care plan and what we do with it. So this slide is really here just as a reminder, again, that when we talk about survivors, that we're not only restricting it to patients who have completed their treatment and are moving back to kind of the life as a post-treatment survivor. So as you can see here, for many patients, this is a kind of a continuum where they get diagnosed, they get treated, and then they go into survivorship. And then they might get diagnosed with another cancer, and they may sort of start the pathway again. But there are some patients who really never leave this pathway, in that they are in, chronic treatment. So patients with metastatic cancers, metastatic breast cancers who can live for a long time, but never sort of get to post-treatment care. And so I think it's important that as we develop programs focusing on survivorship, that we don't leave our other survivors out of the picture, patients with metastatic disease or patients who are chronically on treatment such as CLL. And this is something that, I've previously addressed, which is living with advanced cancer and the role for primary care provider. So again, here, the role is a little bit different. What we do is a little bit different, but in many respects, it's still, quite similar as for patients who have completed their treatment. So what do we go from here? So we went over the quality of cancer survivorship care and what are the pieces that we need to pay attention to. And it's important that when we think about education and training, that we do look at training of primary care physicians, but we also look at training for other healthcare providers, including cardiologists, including gastroenterologists, physical therapists, and oncology providers as well. So let's talk about primary care providers. So there are definitely hurdles for PCPs to care for cancer survivors. Cancer survivors are diverse, and some cancers are rarely seen in primary care, so we really can't have enough expertise in order to take care of these patients. There are some cancers that are very common in primary care, for example, breast cancer, colorectal cancer, prostate, but other cancers may be much more rare in primary care settings. There's often inadequate information about the previous cancer and/or its treatment. So a patient might have had DCIS, and in their view, they had invasive breast cancer. So it's important that patients do have the information. And again, that's where a survivorship care plan could be of benefit. As I mentioned earlier, there's lack of knowledge and confidence about survivorship care among primary care providers. And patients think that too. They feel that the PCPs do not have the confidence to manage them after cancer. There are competing demands on PCP for their time. So we have to meet the metrics for blood pressure control, for diabetes, for vaccinations, for cancer screening. So adding yet one more thing to a PCP can be challenging. And I alluded to this in the past, just before this, which is that there are many times numerous specialists who are involved in cancer care. And so that leads to challenges in communication and coordination. And then lastly, I mean, what has been highlighted for oncology providers in the oncology workforce is the shortage. And of course, for primary care physicians, especially in certain areas across the US, there are real significant shortages. I mean, even in the Boston area where we have plenty of PCPs, oftentimes patients have to wait months in order to get an appointment to see their primary care physician. But there are great resources out there, and these are just a few. So these are cancer survivorship guidelines that are available through various organizations like the Children's Oncology Group, NCCN, the American Cancer Society, and ASCO. So if you're not aware about those resources, definitely do take a look. There are apps that are available as well, including ASCO, NCCN. I love the app for the bone marrow transplant. It's from Be the Match. And the ASCO Cancer, the American Cancer Society actually has a really nice app for that as well. Up to date with a disclosure noted below, we have a growing section focusing on cancer survivorship that has many, many topics focusing on a variety of different cancers, including many of the areas that I mentioned at the beginning of the talk in terms of long-term issues. And then, again, it's important that all providers have some core competencies to take care of cancer survivors. I have had patients who have come to me to the survivorship clinic who were cared for in other settings, who were followed by, for example, by cardiologists. But the cardiologists even were not fully aware about the potential late effects, for example, of radiation therapy. And a lot of the management decisions that were being made did not take that into consideration, and sort of looked at, a 40-year-old as a, sort of a young, healthy person, despite the fact that they had Hodgkin lymphoma, as a young adult treated with radiation therapy and cardiotoxic chemotherapy. So really, as the number of cancer survivors continues to grow, it's important, again, that we educate all healthcare providers. And there are lots of different programs that are available there, including those listed here on this slide, as well as ASCO and others. We, sort of the right bottom corner, we at Dana-Farber had an ongoing in-person CME for many years, and actually pre-COVID, we decided to turn it into a virtual one, and unfortunately, it's a little bit delayed because now everybody is turning all of their programs into virtual. But in the very near future, we will have a multi-module cancer survivorship CME that will be virtual and interactive. So one thing that I wanted to touch base about is a little bit about risk stratification. This is something that has been proposed for many years, which is essentially figuring out what are the ways that a patient can be risk stratified in terms of their risk of late effects and other outcomes. And based on the risk stratification, they can then be sort of directed to the right place of care. And so there are many factors that can be put into the risk stratification criteria. For example, time since diagnosis, risk for recurrence, presence of toxicities, what kind of cancer they had, their patient factors, the setting and type of cancer survivorship provider. So for example, then the high risk patients can then be followed in certain settings and the lower risk patients in others. And this was just, one of the schematics that we published, kind of taking a look at how the risk stratification may happen and what type of healthcare provider may then be designated to do survivorship care for that patient. And so here, right, is based on the risk stratification, let's say if you have a low to moderate risk patient, then a general primary care physician can really be the, patients can then transition to PCPs, plus or minus continuing to see their oncology provider. And then sort of the other way is kind of a model of Oncogeneralist, and I will talk to you a little bit about that, is somebody who has a deeper understanding about cancer survivorship and can be then seeing complicated patients and teaching others, sort of a geriatrics type model. And so what is an oncogeneralist? Essentially, as one of my colleagues has termed it, she said it's an oxymoron, but I think that, there's now this growing field of oncocardiology and oncoendocrinology and onco everything. And so it's basically a general internist, a family physician who has some greater understanding, training, education in oncology care. And so this will take you now to me. I have a dual role, as was mentioned, in that I am both a primary care physician and I'm also a cancer survivorship physician. And so oftentimes I will be asked the question of, well, how did you end up doing what you're doing? And I say that I always liked oncology, but did not want to be an oncologist. And with all due respect to all of the oncologists in the audience today, I love working with all of you, but I am so happy to be doing what I am doing. And so just a little bit of a historical background. And, this was interesting. I was cleaning out my basement a while ago, and I found this paper that I wrote as part of a science journal in my high school. And that's over in the top left corner there. And so this was written in the 1980s, Cancer Approaching a Cure. So I was actually kind of dumbfounded that I actually was interested in cancer going back then. And then in medical school, I worked on my very first research project focusing on endometrial carcinoma in elderly women, and then pursued my residency at Yale back in the day when bone marrow transplant for women with breast cancer was quite common. And one of my early projects is I did an analysis of, are we doing any better in treating metastatic breast cancer patients? And then I finished my residency and pursued a general medicine fellowship at Harvard Medical School. And when I first entered that program, I was interested in breast cancer screening. Really did a lot of work focusing on cancer screening, a lot of research in the field. And then hit the sort of the early mid 2000s, and there was this great focus and sort of attention being paid to cancer survivorship. And at that point, I decided that, well, this is an area that I really would like to pursue. And then, of course, being a typical medical school residency grad, especially back then, but certainly I think even still now, I had no idea what I'm doing. Like, I don't know cancer survivorship. I never learned any of this stuff. And so then I started learning, and this was actually a pivotal moment in time when I said to my colleague, I said, well, maybe I should do an onc fellowship. And she said to me, do you want to give chemo? And I said, no. So then she said, well, then you're not doing an onc fellowship. Just do survivorship based on who you are. And so then I basically started to learn and took part in a whole bunch of CME programs and other programs just to get a better understanding. And then I practiced, and I started paying more attention to patients in my panel who were cancer survivors, and started doing a kind of a deeper dive into their cancer treatment and actually just talking to the patients about their experiences. And then I started studying cancer survivorship and doing research focusing on the field. And voila, I became an expert because there were so few and there's still so few. So that's, one of the benefits of sort of entering a field when there are so few of us in the field. And then as I became an expert, I started to practice some more, and at that point started to practice actually as a survivorship physician at Dana-Farber. And prior to my role, there was actually another internist who was seeing survivors at Dana-Farber, so the transition was actually easy at that point. And then I started to educate, and that is, being part and running and promoting many programs, as mentioned, as well as leading policy, working on guidelines with ASCO and CCN, lobbying on the Hill, giving speeches at the Institute of Medicine. So where are we then in summary? So the focus of this series that you're putting together is on cancer survivorship, and then for my talk specifically on building bridges between oncology and primary care. So what are some tips for primary care providers? One is continuing education, continue to learn, continue to grow, ask about personal history and family cancer history, refer patients to specialized care when needed, co-manage them during their active treatment, and really support patient in self-management. And how about for oncology providers? The important piece there is examine the patient rosters. Do you really need to see a patient who had early stage DCIS 20 years ago, who's had regular mammos, has been completely fine? Does that patient really belong in your care, or should that patient really be transitioned? Triage patients who need specialized care. So sometimes oncology providers may not be the best ones to see very complicated cancer survivors. Build bridges with primary care, also support patients in self-management, communicate post-treatment expectations. Don't just have that last visit with the patient unbeknownst to the patient and say, okay, we're ready to transition you to primary care. Make sure you mention that beforehand and get them prepared for their transition, and reinforce expectations. I am thrilled that Spectrum Health Cancer Center is hosting this series on cancer survivorship. You've got an exciting program coming up, and I am very grateful for you to be invited to lead this off. So thank you very much.
Well, thank you very much, Larissa. That was I'm really not saying that because you're on the other side of the screen, but this is the best survivorship talk I've ever listened to. And I've been going to these, God knows, for the past 10 years.
Thank you.
And I'm glad you mentioned that. Last year, we always pick the topic for next year's symposium. And we decided as a team last year immediately that we're going to do survivorship next year, because we know the importance of this to our patients, to our community, and to our actually colleagues, just to put team together. And I would like to see if we have any questions from the audience. But as I'm waiting to see if anyone will raise their hand or they will write it in the chat box. Tell me a little bit more about, unfortunately, we have to admit that there's lots of problems in financial support for these. How do you get it reconciled at Dana-Farber Brigham?
Yeah, so I don't know specifically because I don't get into those pieces. I'm not a director sort of on the financial side of these programs. From what I understand, it's through benefactor support. There's definitely sort of this kind of this foundation that's set on those stable funds from year to year. We do bill for services. Sort of how it works out at the end, I'm not entirely clear. But I mean, in some ways, I guess my position has always been that, from a cancer center strategy, right? I think it would be really unfair to claim success for curing somebody's cancer when So you cure somebody's Hodgkin lymphoma, but then they die of breast cancer because you didn't adequately address their needs, or they died of heart disease because there was no focus on cardiovascular health. I think it's sort of, time to reassess, for cancer centers, how they can claim success for a cancer cure when overall we're not curing the patient.
Thank you very much. Thank you. That's true. It is really a collective effort. I agree. And we have to figure out how to put it together.
Absolutely.
If you have a question that you'd like to ask you could unmute, and we will be excited to hear your question and the answer from Dr. Neklyudov. I hope. Okay. All right. So we have a question from Emily. It says, where in EPIC is your survivorship care plan located? That's for me, actually, I think. We'll have to discuss about that, Emily, later, because unfortunately, there are some operational issues in the cancer practice here at Spectrum Health. But if you would like to email me, we can discuss that offline, anas.aljanadi@spectrumhealth.org.
I could tell you for us, it appears in a separate folder that's called Treatment Summary. And when I have asked my primary care colleagues, I actually asked them a question, have you ever received the survivorship care plan? And I received a whole bunch of interesting responses to that question, including one that says, no, but if I ever get one, I'll let you know.
Where's Waldo?
And so, but even seeing where it is, it's sort of not intuitive for a primary care physician to say, oh, click on treatment summary, because we don't think in that way. What is a treatment summary?
I don't know if anyone from our team, Jerry, Robol, or anyone have any comments to add. If you know, where do we have it? And we have it, I'm sure we have it under treatment summary as well, but for a limited, it's a long story. Maybe I can share with you later, Larissa, what's our story here.
I'm sure.
Any other questions? I am glad that you are really dedicated yourself for the service, because as you said, the more we have really, as everyone now knows, that survivorship has increased significantly, and there will be more issues to manage. People will live longer. A higher number of patients with cancer will live longer, whether with or without active malignancy, with or without active therapy. And without putting a system to take care of them, you're absolutely right. We will achieve history on success and victory in one front, and we will lose the rest of it.
Absolutely.
Well, if there are no other questions, I really would like to thank you for your time and participation, and we highly appreciate your expertise. And I will probably reach out to you offline when we are trying to establish our comprehensive cancer survivorship here at Spectrum Health.
Yes, absolutely. Well, thank you again for featuring cancer survivorship. Thank you for inviting me. And if anyone is afraid to speak up, feel free to send me an email here. And I'm also new to Twitter, but you can definitely follow me for sort of cancer survivorship related information.
Thank you very much, Larissa. Pleasure. Hopefully we'll when life is back to normal, we'll meet each other again.
Sounds good to me. Thank you.
Okay, bye-bye. Okay. Well, this is Catherine has on the screen. If you if somebody if you can see her screen, I'd like to remind everyone to join us tomorrow for a very important talk that is gaining traction. Financial toxicity in cancer care is is a major dilemma. And I hope you will enjoy the talk tomorrow, assessing what is the burden of financial burden for the patient and the effect or the effect of that burden on outcomes. We will also have a roundtable, if you will, discussing managing side effects of surgery. That will be, and our panel will be Dr. Amy Hopp of our breast care team, Dr. Marty Luchtefeld from the Digestive Health Disease Institute, and Dr. Paul Wright, Section Chief of Breast Care at Spectrum Health. So same mechanism tomorrow. I hope most of you who joined us today found this worth your time and you found benefit. And hopefully tomorrow also we will have a great session for you and also for the rest of the week. And thank you all for joining us.